Hello, welcome everyone to my channel Haemodialysis Simplified. In these small sessions, we will be discussing on various aspects of hemodialysis. In this particular session, we will be discussing more on central venous catheters for hemodialysis in a little bit detail. So normally, any patients on maintenance hemodialysis, they must have undergone some point of their time some kind of central venous catheters. So the learning objectives are what cases we will use central venous catheters and common site of placement of central venous catheters, type of catheters with a little bit of more description, catheter placement method, how to place the catheter and what caution to be taken, and how do we see whether the catheter is placed properly. Then one detailed explanation will be on possible recirculation in central venous catheters and how to minimize it. That also will be discussed in a little bit details. One more common problem with central venous catheters are infections, how to minimize the infection or prevent the infection. Exitscare is another aspect which we will be discussing a little bit, and some complication related to central venous catheters. So let's go to the session. As a standard protocol, you may check with your medical condition or medical officers before changing your procedures. This is only a guideline. You may take the final consent from your concerned medical officer for changing any protocol in your center. So let's get started. If you look at central venous catheters, it is basically placed through the skin to one of the larger central vein, like internal jugular, subclavian, with tunnel or without tunnel. There are various methods, and femoral catheter. These are, I'm taking only the prominent form of central venous catheters, not the other way. Sometimes it is placed in various places as well, but as a common procedure where it is placed to a central vein. For this is normally meant for acute hemodialysis. Suppose someone come all of a sudden for hemodialysis. Most of the hemodialysis patient, if you look at the history, they must have landed up in an emergency or in a critical care scenario where they may not be knowing that they had kidney failure, and all of a sudden, maybe because of the ESRD or CKD, their GFR must have reduced to larger extent, or they may be in pulmonary edema or metabolic acidosis or hyperkalemia. They may all of a sudden require dialysis, where the catheters, central venous catheters, especially jugular, will be a great use. So again, this is meant for short-term use till if they are on CKD and require longer dialysis, in numbers or long-term dialysis, there will be a permanent vascular access made, like AV fistula in an ideal case scenario. These catheters are used till the permanent vascular access develops. And some other choices are, some patient will have very poor vein which is not adequate enough to create a permanent vascular access. In those cases, these patients may require central venous catheter for longer duration, sometime weeks or months or years together, like permanent catheter, the so-called permanent catheters. Then in case all of a sudden the permanent vascular access failed, they would require central venous catheters for a dialysis session in case of any untoward incident. However, the advantage of these catheters are it can be used immediately after placement, and especially in acute renal failure patients or in intensive care unit, the internal jugular catheters or femoral catheters are commonly used, and that will be an advantage for them because permanent access may not be required, and if at all it required, it take longer time. So let's look at the various locations of central venous catheters. If you see here, you can see here this is the jugular, and this will be a subclavian or a tunnel catheter or a permanent permanent catheter or perm cath, the so-called perm cath placement, or they may require a femoral catheter. We will discuss a little bit in detail in the next slide. So these are the location again, internal jugular over here, subclavian or perm cath with a tunnel can be placed over here, and femoral catheters are placed in the femoral vein. So if you look a little bit of the viability of this catheter, jugular catheters are easy to make and most used in suddenly the dialysis required or acute requirement of dialysis, where the complications are lesser, and it need to be checked by an X-ray after placing the catheters to understand whether catheter is in the right place or there is a haemothorax or pneumothorax in the patient, where there is a arterial puncture possible and the blood collected on the lungs or in the thoracic cavity. So this require an X-ray and to visualize the catheter position as well as if there is any internal hemorrhage inside. Subclavians are a little bit difficult in making because this require a lot of expertise, and it take a little more longer time to place, and we require some gadget to examine whether it is placed correctly or it's on the right place, the tip is in the right place, all these aspects. So again, this require a very skilled person to make this catheter, because by accidentally if you puncture an artery, then it can be very dangerous to the patient. So this required extreme skill situation to make this jugular. Jugular is easy, subclavian or permanent catheters or the tunnel catheters. Femoral is relatively very easy in case a patient come with extremely high pulmonary edema where they are not able to lie down flat for making a catheter, or they require dialysis in acute renal failure in intensive care. Femoral catheters are used. It's easy to make. It can be done within few minutes, but if you keep it longer, there are higher chances of infection. Whereas the advantage is it's very quick or easy to make. So if you look at a standard temporary catheter kit, this is typically a catheter kit which nowadays available easily, so that you need not procure each and every item separately. So a typical kit comes with a catheter of your choice with various length, which is available in the market depending on the size of the patient, whether it is pediatric or medium built or heavy built patients. So this is a catheter, and the placement again, this is, as I mentioned earlier, require a little bit skill set. Normally an introducer needle is used after analyzing the position of the vein with a saline, little bit saline taken in a 5 ml syringe or 10 ml syringe. A saline is flushed through the catheter and kept ready, and an introducer needle of 16 or 18 gauge preferably taken. 14 gauge, I think 14 gauge is ideal. And once you get the blood flashing through this area, and a guide wire is introduced through these needles, without any resistance. If there is a resistance, we need to pull it back and again readjust the position so that this is perfectly on the vessel. Normally a J-tip catheter is used, J-tip guide wire is used because this will avoid injury or rupture of the vessel. So once the vein is traced, a guide wire is introduced through that to almost larger extent depending on the size of the patient, but it should be free going. It should not, we should not exert too much of pressure. That means this is not in the vessel properly. So once that is introduced, a guide wire is introduced. This guide wire helps as a guide to introduce a catheter. So once the guide wire is introduced almost the desirable level, then this introducer needle will be removed, and with a scalpel blade, a small incision is made on the skin. Then through the guide wire, a dilator is introduced. There are again different type of dilator available. So the dilator will help in easy passage of catheter, and it dilate the vessel for the easy passage of the catheter. So the dilator is used for dilating. After that, we have to exercise a little caution to avoid excessive bleeding while removing the dilator. Once the dilator is removed, then through the guide wire this catheter can be placed. Once the catheter is placed up to this, you will see the blood coming out through both the limbs. Then we need to flush it with the normal saline, and proper heparinization is required to avoid clotting. After that, we can anchor the catheter because the wing of the catheter contains some anchoring portion where you can suture it over the subcutaneous area so that catheter will be stabilized. Once everything is done, then we need to secure the cap. So this is the procedure of introducing a standard temporary catheter, and now it's available in the kits, so it's easy to make, easy to insert, and it's conveniently available. And if you see a little bit magnified way of this catheter, you will see a so-called arterial limb and a venous limb is color coded, and internally it's a single catheter, whereas if you take a cross section of the catheter, you can see the passage of artery and vein separately. So this will be again various gauges, and various size of catheter is available in terms of length, and the diameter of the catheter also will be mentioned over here. Length of the catheter will be mentioned over here. So we can choose or order what size of catheter we require. And most importantly, there is something called priming volume of each limb, meaning the volume of solution or heparin or whatever you fill it to prevent the clotting. The volume, how much volume it can hold, that's called the priming volume, which is normally mentioned over the limb of the catheter to make easy for the user to use right amount of anticoagulation without giving too much to the patient or lesser in the catheter. So adequate filling is possible by seeing the volume in the limb. So just wanted to say a little bit, there are various type of channels or various type of holes inside. Some will be coaxial in nature, meaning one round in the middle and one round on the periphery. So it's available basically on different type. So we can choose the right catheter according to the patient body size and the requirement. So it's very convenient to use it. If you come into the permanent double lumen catheters or permcath, the so-called permcath, this is supposed to be lasting for months or years, whereas the placement techniques are quite different. It requires a lot of skill, a kind of surgical procedure have to be adapted to do this. And the structure is more or less the same. You will have a lower law connection at the periphery, with clamps, and you will see the entire silicone tubing. So this will be visualized through an X-ray. So this will be radio opaque. So you will see this, and over here you can see a dacron cuff where we will be anchoring the catheter, and this portion from this Y junction, almost this Y junction to the dacron cuff or tunnel, will be subcutaneously placed. So this will actually enhance the growth of epithelial tissues over there, and it heal faster, and this will be securely placed. And the distal portion can be seen or till the tip by an X-ray. If you see the tip of the catheter, this is very, very important, because we should have a fair understanding on the tip of the catheter, how it is placed. So the arterial lumen will be almost towards the end of the catheter, about 2 to 3 centimeter before the tip of the catheter. There will be pores over here. This will be the arterial lumen, and this is the venous lumen, which blood go back to the patient, and through this blood will be sucked into the system and for the dialysis extracorporeal sets, and after that it will be delivered through the venous cannula, and the lumen will be over here. So this can be given a little more in detail in the coming slides. So what is the difference in terms of temporary and permanent catheter? As I mentioned earlier, the perm cath, which just now you have seen in the previous slide, is meant for using months or years where there is no possibility of a permanent access. So the lifetime of a temporary catheter may be a day or a few weeks, whereas permanent catheter will come for weeks or years. The material is more or less the same polyurethane and silicone material, and lumen is both single lumen available in specific cases, but not in larger extent nowadays unless it is required in case of temporary catheters, whereas in permanent catheter it will be always a double lumen. If you see the tunnel in temporary catheter, since it is meant for a shorter duration, there won't be any tunnel, whereas in permanent catheter there will be a tunnel which largely prevent direct infection transferring through the skin into the vessel. So it will delay, or we can see the infection beginning at the beginning itself, so that we can prevent infection into the blood. And in temporary catheter you don't see a dacron cuff, whereas in permanent catheter it is available. Implantation technique in temporary catheters are normally through guide wire, as I mentioned earlier, how the guide wires are used. Whereas in permanent, it is guide wire assisted, but the tip of the catheter will be a kind of split cannula, where we use a kind of stillet to pull it out, and it requires a lot of skill to place these catheters. So sometime we need to look at the real-time ECG and some ultrasound assisted devices to visualize the position of the vessel as well as the catheter positions. So if you look at that, why this slide is over here is, once we place the catheter, we need to make sure that the catheter tip is in the right place. Otherwise, patient may get a little bit of arrhythmia kind, or a discomfort, or a kind of sucking feeling, or they feel a little bit uncomfortable or vibrating catheter during the dialysis especially. So this is the relative guidelines. So this green portion is a catheter. If you see here, and if you see the ECG, that's what the ECG assisted procedure is coming into the picture. This will be just like a normal ECG. Even in the catheter, if it comes to the rim of the heart, still the ECG is normal. So this is a physician choice whether they have to keep it over here, or the tip of the catheter. But ideally, this will be good enough. This position will be good enough. Whereas if the catheter is too deep in nature, then you will see the ECG changes over here. So this I'll come a little bit detail in the next slide. Whereas ideally this is the position, or if not, this can be the best case scenario, but not like this, because patient get a little bit of discomfort once the catheter is too deep in place. And these two are again the mirror image of the first two pictures. So if you see here in this ECG, if the catheter is placed in the right way, the ECG will be reading like this, especially the P wave. So if the catheter is deep in place, as you've seen in the earlier slide, you will see the P wave will be elevated a bit, elevated as good as R wave. So P wave will be elevated if the catheter is placed in a little deeper. So that's what the importance of ECG guidance is. Like if a patient complain of some discomfort after putting the catheter, in case they are feeling a little arrhythmia or they feel a little vibrating sensation after placement of the catheter, we may connect them to an ECG. If you see that if the patient's P wave is elevated, then we have to suspect the catheter is a little bit deeply in place. So that's the importance of having an ECG in this scenario. So once the catheter is placed, this will be like this, either in internal jugular or in the subclavian. So this will be just to say that these are the locations used in these two catheters. This can be a temporary catheter, and this can be a tunnel one for a perm cath for a longer time. So once the catheters are placed very neatly, this look like this, very clean and no discharge, no blood coming out or no fluid oozing out, and it will be dry in nature. And we need to apply a kind of transparent padding over here so that we can see if there is any discharge coming out from this area. And again, to give a little explanation on the straight internal jugular catheter, once it is placed, it will be looking quite neat like this. So that means this catheter is not having any issues in terms of discharge or infection on the exit side. This is another important slide because this need to be understood properly to have a better understanding on the tip of the catheter, because tip of the catheter matters. You will see it in the next slides why it is so important. So if you take the tip of the catheter, if it is like this, you will see the lumen, small opening over the tip over here. So the venous return will be through these pores and through this distal tip of the catheter. So this again I repeat because this catheter is a double lumen catheter having two lumen inside, whereas if you see from outside it's a single catheter. If you see the venous lumen, it will be on the side towards the tip, and towards the tip it will be a distal lumen, like a larger lumen over here. Whereas if you see the arterial lumens, it will be much behind the venous lumen over here. This will be almost like from the tip it will be about 2 to 3 centimeter apart. So these are the arterial lumen where blood is sucked into the extracorporeal system into the dialysis set, and blood will be returned back through these lumens towards the tip and towards the side of the distal tip. So this will be the venous lumen. So if you have a good understanding, then you will understand the next slide. So this is the normal scenario where blood is sucked into the catheter for dialysis circulation. It will come like this, and once after the dialysis, this will be returned back to the patient through this lumen. Whereas this catheter is placed in the venous side because we cannot make a catheter on the arterial end because of the complication involved. And venous puncture is very safe compared to the arterial puncture. So this will be in the lumen. So this is the arterial pore where blood is flowing into the dialyzer, and after that it go back to the patient through this. This is a normal scenario. Whereas in general, suppose this distal end in some catheters or some make or some company make, suppose these are shorter. If you see here, there is a visible difference over here. Here this is a longer portion. Here it's a smaller portion. So what happens over here is part of the blood which is coming back from the dialyzer, or the so-called purified blood, which again pass into the arterial lumen. So that's called recirculation. So this will be a little common in normally in dialyzer up to 6 to 8%, which is okay, which cannot be avoided in most of the situation. Whereas by mistake or sometime when we aspirate the lumen, we don't see much flow through the arterial cannula, whereas venous will be very, very patent, and it will be quite flow will be quite easy through this venous. So sometime as a practice, people reverse this connection, meaning instead of taking out blood through this, the blood will be taken out through the venous cannula and returned through the arterial cannula. So that's the scenario over here. Instead of taking blood through this, it will be taken through this venous cannula. So when you take blood through this venous cannula and return it back to the patient after dialysis, larger portion of the blood which is returned to the patient have to pass through this area where there will be extremely high suction pressure because of the blood pump running in a high speed. So almost like larger portion of the blood will be flowing back, meaning the blood which is dialyzed is again flowing back to the portion where the blood will be sucking into the extracorporeal system. Meaning, if you reverse it, the larger portion of the blood will be again passing through the place where the blood is taken for dialysis. So the recirculation amount will be extremely high. I'll explain this in detail in the next slide. This is a scenario. If you reverse a catheter, meaning instead of arterial connection, if you connect this into the venous part of the blood, and this one you connect into the arterial part of the blood lines. Suppose you connect this into the reverse way. If you see here, sometime, as I said the scenario earlier, sometimes there won't be flow through the arterial cannula. So people tend to reverse the cannula connection. Instead of A, they will connect that into the V and V into the A. So what happens here? A large portion of the blood which is coming back to the patient will be again flowing back into the extracorporeal set, where the recirculation can go up to 50%. So this is not a great practice. Again, we need to take care of the catheters extremely good way, otherwise we will end up in various trouble. So the aseptic techniques in handling the catheter is very, very important especially during connection and disconnection, because these are the two times when the catheter is exposed outside and getting open. So there can be a contamination during connection and disconnection. So we need to be very careful during these two procedures. And also we need to see the skin inflammation at the exit site. This has to be done in every dialysis basis. And we have to flush the catheter after the dialysis with sodium chloride solution and use appropriate anticoagulant, either heparin or citrate or any other catheter lock solution which is practiced in the center. So this have to be thoroughly followed, and there are right method of doing it which will come into the subsequent slide. One more practice, probably a good practice, is that examine the catheter exit bandage or exitsite bandage or dressing before the commencement of dialysis rather than doing it after the termination of dialysis. So it's recommended to do it before the dialysis so that if there is any alarming thing, we can handle well in advance. Otherwise, patient will be in a hurry to go home after dialysis. So this will be a little challenging. So one more thing we need to look into that is sometime anticoagulation, filling an anticoagulant agent on the catheter. If it is the wrong way, wrong concentration, it can cause clotting inside the catheter. If you see a clot when you open a catheter before dialysis and do aspirate to remove the heparin or anticoagulant and remove the clot, if you see a clot more than 3 centimeter in length, that shows that your practice of anticoagulant may be wrong, or you are doing wrong concentration of anticoagulant, or the flushing method may be wrong. So we need to be careful when you see longer clots before you start when you aspirate the catheter. So any clot of 2 to 3 centimeter, we need to be cautious that time itself. It may be because when you flush heparin, we will be doing a passive method, meaning we are using bigger syringes, especially 20 ml syringes, and you are taking 2 ml of heparin. You cannot exert great pressure when you push the heparin. So this need to be pushed in a great pressure so that there won't be any backflow simultaneously. So the method is just jet flow through the catheter and simultaneously close the cap, or I mean the clamps over here. It's a simple practice. Push and simultaneously close it so that the heparin will be locked perfectly without any backflow. The clot formation could be because of the backflow through the catheter, and some people have a practice of after pushing they will aspirate a little and see. That is a wrong practice. That means the tip of the catheter will be having still blood, not heparin, and after two days this portion get clotted and patient catheter might get clotted. So this carry a lot of risk. So the filling procedure is a kind of jet flow and clamp simultaneously. Use always 5 ml syringe or even 2 ml or 3 ml syringe for pushing anticoagulant is ideal, and do not use 20 ml syringe for filling anticoagulant because you cannot take accurate amount of anticoagulant in a 20 ml syringe or 10 ml syringe. So ideally 5 ml or lesser is accurate. So filling volume or priming volume normally will be written on the limb of the catheter. You can read that what is the amount of anticoagulant required for each limb. Preferably fill both the limbs separately, because once you take, suppose you are taking about here, it require about 2.9 ml. So you may sometime get difficult accurately pushing 1.5 ml and 1.4 ml if you take it together in one syringe. Ideally, it is better once you take 1.5 ml and push through this cannula, close it, and 1.4 you take it in this cannula and close it. So accurate filling or optimal filling will be there, or either otherwise it may be underfilled or overfilled, which may go into the circulation. So use right volume and concentration of heparin. That's the thumb rule for preventing the clots in the tip of the catheter. Again, if you look into how to minimize or reduce or avoid infection in a catheter, we have to follow the aseptic techniques which I mentioned earlier. Hand hygiene is very, very important, and wearing a mask both by patient and caregiver is recommended. always follows two people starting and ending procedure, because sometime what happen, one person will be handling both catheter, catheter care, meaning opening the catheter, cleaning the area, and uh, putting dressing, then aspirating the catheter, flushing the catheter to see the patency, and after that giving connection. So with one person, it will be, there is a chance of compromise and contamination. It's always better to have two-person, one person to handle the catheter, another person to give connection to the extracorporeal set. So this is always recommended, two-person instead of one person handling the catheter, and thorough rinsing of catheter tip before giving connection to the bloodline is very, very important, because this is one area where there can be a contamination, because bloodlines are exposed too much of time in the machine, and the tip must have touched several times. So we need to follow the cleaning procedure of the tip of the catheter as well as the bloodline from top to down wiping method. So that will help in preventing touch contamination. And the patient first approach, this is another way to minimize the infection, because most of the time what happens is, once the catheter patient dialysis is terminated or dialysis is over, people after returning blood, they'll be removing the bloodline from the catheters, and they will take it out from the machine, and they will be focusing more on the extracorporeal set removal rather than the catheter, and the catheter will be exposed and open for longer time. So first we need to take care of the catheter. So that's a patient first approach. We need to first take care of the catheter. Extracorporeal set anyway we are going to discard. We need not give much attention rather than giving attention to the catheter and the patient. Then again, don't leave the catheter ports after disconnection for longer time exposure. This also can cause infection. Exit care, as I said before, exit care should be given before commencing dialysis, not after the dialysis. Over here, this is the exit care scores. When you examine a catheter, this will be an exit care score. If score 0 means this catheter is very clean, no discharge, healthy skin, no, and quite intact. Score 1, if you see a little bit of reddening, about 1 centimeter around the catheter, and you will see some fibrin over here. Score 2, again you will see reddening about less than 2 centimeter around the catheter. You will see here. This is again a warning sign, and score 3 is quite bad. Actually, it's quite infected, and you will see the reddening, secretion pass around the catheter, discharge, and wetness over there. So every day we need to examine the catheter exit side, and it should be something like this. So this is a healthy exit site for a patient. So that's what I need to say. Again, the complications in central venous catheters are not uncommon. There are many complications, which I'll be talking in detail in my next presentation. In detail, because this is a very, very large topic. So we have to have another session, because this session can be very lengthy otherwise. So exit or tunnel care infection, this is mainly in the permanent catheters. Pneumothorax, this could be an insertion related issue. Haemothorax also. Here in pneumothorax, you will see maybe some blood collection on the thoracic lungs, and hemothorax may be some blood collection over the thoracic cavity. Arrhythmias may be related to insertion and the catheter tip positioning. Bleeding, infection, and thrombosis on various way, like vessel thrombosis or catheter clotting, sepsis, or air embolism if there is an accidental disconnection, which all these we'll be discussing in the subsequent slide, the subsequent presentations. because this presentation already exceeded more than 40 minutes. So thank you very much for your attention. Looking forward to see you soon in the next presentation on this subject. Thanks a lot.